So I think we have two cases so far of put your money where your mouth is and demand some accountability on the other end. And we have one more presentation. So this is Richard Valachovic.
That's
Did
it.
I pronounce that right?
That's
Good.
close enough.
President and CEO of the American Dental Education Association to talk about financing dental education.
All right. Whoop. Here, a little bit ahead. There we go. All right. Good afternoon. So by training, I'm a pediatric dentist, and when I would begin a procedure on a child, I'd say, if you'll be quiet, I'll be quick. So let's get underway. If you'll be quiet, I'll be quick. So let me provide some context about the dental care and dental education market. There's about 160,000 dentists in the United States. We graduate now about 5,500 new dentists a year. 90% of dentists are in private practice, so leaving only 10% for everything else, faculty, military, public health, all of the other kinds. About 85% of dentists are in 1 to 2 person private practices, the kind of things that in suburbia, the bungalow kind of practices that we think of. Those of you in downtown DC, 1145 19th Street is the dental building. But there's some consolidation going on in the market right now. Those of you who know about Aspen Dental or Heartland Dental, Pacific Dental, the creation of these large group practices. And different than medicine or PA, for example, 80% of dentists are generalists, only 20% are specialists. From the coverage perspective, less than 50% of Americans have any kind of dental coverage. Dental insurance is really a misnomer. Nobody has really a risk-based insurance. It's just a dental benefit. Those who have it, there's co-pays, deductibles, annual limits. Medicaid has been an optional state for the states to have for dental, but it became an essential benefit for children in the ACA, and it has already demonstrated an incredible impact on the dental health of children in the Medicaid population. But it's still is an optional adult benefit. Even in the People's Republic of Massachusetts, they provided for a dental benefit of cosmetic repair of the upper 6 teeth so that you could get a job, but not for the health of the remaining. If you can pay for dental care, you're probably okay. But the access to care for the rest of the population remains a considerable issue. We, from both a dental education and a dental practice perspective, we teach to a 1/10 of a millimeter. That's success or failure in dentistry. A restoration, the placement of an implant, a variety of other things that we do is to a 1/10 of a millimeter. So when we talk about well-being, wellness, and the kinds of compulsive behavior that we actually inculcate in our students, it's to the 1/10 of a millimeter. So we see about 500 million, we have about 500 million patient encounters a year. We see patients when they're well for the most part, which means that we have an opportunity to engage in care in a way that we have not done before. And I think as we move forward, we hope that we can become part of that. Our national expenditures are about $113 billion a year, which is roughly equivalent to those expenditures on outpatient cardiac and outpatient cancer care. So to put that in context to some degree. But also remember that the National Institute of Dental Research was one of the 3 original institutes at NIH because draft deferments because of dental health were the number 1 reason. 4F, for those of you who remember the draft, came from 4 front teeth. You had to have 4 front teeth to be able to pop open gunpowder cartridges in the Civil War, and that was what remained. Through Iraq and Afghanistan deployments, that remained a considerable problem, in that the major reason why troops weren't deployed to Iraq and Afghanistan was because of their oral health. We have 66 dental schools in the United States. About half are public, half are private. There are three major sources of revenue and expense: either tuition, clinic operations, and research, and that's it. And essentially, all clinic operations occur within the footprint of the dental school predominantly. There are other places, but unlike the enterprise of the academic health center, with the way that the medical school, nursing school, pharmacy school, and others interact broadly, the dental school is relatively self-contained. And so the tuition really drives much of it. Where public schools used to be state-supported, they have become essentially state-located. And there are some public schools where the tuition of the dental school is higher than some of the local private schools, which has become a problem. So I just wanted to run through some of the issues in dental education in the United States, using the guiding principles framework from this morning, starting with some of the issues related to the disease burden. I think that you know that we have three major issues in dentistry: dental caries, cavities in teeth, periodontal disease, and oral cancer. This just explaining, beginning with dental caries. In children, 14% of children ages 3 to 5 overall have caries, have dental caries to some degree, but of course in white children, it's only in 11%. But then when you look at below below 100% of federal poverty level, it's 25%. Then going up at 6 to 9 years of age goes up, going down a little bit as you age, as care gets provided. In the adult population, if you think that 28 teeth is what you would hope to be able to maintain, in 25 to 44-year-olds, on average, about 53% of people are able to do that, keep that many, but below the federal poverty level, only 42%. But when you get into the 45 to 64%, it gets down to only 15% of people are able to maintain that. From a periodontal disease, gum disease, however you want to refer to it, half of Americans have some form of gum disease, but periodontal disease, which can be considerable, especially when we think about the issues related to the oral systemic connection. No matter how you think about it, periodontal disease is a source of inflammation. And it mediates through the rest of the body in the same way that any other kind of inflammation does. And then oral cancer, especially with the increasing incidence of HPV, kills as many people as melanoma, and now more common than leukemia. And then the oral systemic connection, as I talked to you about. Now, in terms of, so using the framework from this morning, responsiveness to society, there was sorry about this. There was an increase in the number of dental schools until 1980 during that whole capitation and capital expansion. But then we closed 7 dental schools between 1986 and the year 2000. They were all private. 3 of them were Jesuit. One was Oral Roberts. The Lord was responding to the prayers of practicing dentists. And we went from 6,000 graduates, 6,300 graduates in 1980 to 3,900 graduates in 1990. So, I mean, how many professional schools can you think of that closed with that degree of rapidity? And it was the perception that dental caries had been eliminated. We were talking about the generations of cavity-free kids that had come. So if there was a concept of responding to to a societal need, we did it. Now, since 2000, we've opened up 13 new schools. The majority of them are in universities that have DO granting medical schools. And so a number of reasons for that, but so we now are back up to 66. We are responsive to society in other ways. We have, we're now essentially 50-50 from a gender perspective. And we've been successful from an underrepresented minority point of view as well. We have really inculcated a holistic admissions program throughout our schools, and we have, with the Association of American Medical Colleges, the Summer Medical and Dental Education Program that essentially doubles the chances of students who undertake this summer enrichment program to get into medical or dental school. We're trying to be transparent. Applicants to dental schools between 2000 and 2014 grew at a faster rate than either applicants to medical schools or law schools. We like to joke that our numbers now, ratios, if you can't get into dental school, I guess you'll have to go to medical school. So that's but we're nimble. Where do they go from here? We do a senior survey at the end of, as students are graduating every year, to make comparisons, and the numbers last year are pretty consistent with previous years. You know, our students upon graduation have to be ready for private practice as licensed unsupervised practitioners. They don't have to go to a PGY year, with the exception for licensure in New York and Delaware. Otherwise, go straight to so the 50% go direct into private practice. A third go into a residency program of some kind, then some go into military, public health service, a variety of others, but we have some nimbleness to the system that we have. There is value, you know, in the guiding principles, generate value to actors in the system. Most educational interventions are not evaluated for their cost effectiveness, benefit, or utility. You know, I think that accreditation does do that in many ways. For us, it's CODA, the Commission on Dental Accreditation, and the impact of accreditation benefiting students and residents who are the consumers seeking the education programs, educational institutions, licensing and regulatory bodies, and certainly the public. And CODA, like most of the other accrediting agencies, really focuses on financial sustainability and stability. Lifelong learners, our folks are really big on continuing education. This one of our surveys showing the number of hours annually spent by dentists on continuing education, with what we think is a remarkably long tail over here. Ethical, the issues around students accrue debt for their education and graduate, hopefully with a job prospect, although the average graduating debt is around in the $220,000 range, including debt as they come in from college. You know, we have essentially zero default on any of the loans. The students, the graduates, pay off their loans within the 7 to 10 year range, and that has not been an issue. There is no unemployment. If there is any issue, there certainly is not because of the unavailability of jobs. There is a lot of opportunity out there. And the issue of interconnectedness, certainly we're both from an IPE perspective, we're driving as much as we can to be collaborative in the academic health center, but also from an interprofessional collaborative practice perspective, trying to get ourselves out of just the independent office and practice of dentistry into something that's more collaborative across the board. So, thank you very much.